For the kickoff for this afternoon's program, I'm pleased to welcome Dr. Susan Buchbinder. Dr. Buchbinder is the director of Bridge HIV, which is an HIV prevention research unit housed at the San Francisco Department of Public Health. She's a clinical professor of medicine, epidemiology, and biostatistics at University of California, San Francisco, and her research focuses on HIV vaccines, pre-exposure prophylaxis, broadly neutralizing antibodies, and strategies to support PrEP uptake and use, particularly focusing on addressing racial and ethnic and gender disparities. She's one of the founding members and co-chairs of the steering committee of Getting to Zero San Francisco, an initiative that aims to eliminate new HIV infections, HIV-associated deaths, and HIV stigma. This afternoon, she's going to be talking to us about the art and science of HIV and STI prevention. Thank you, Susan.
Thanks so much, Connie. These are my disclosures. And the learning objectives are that we're going to talk about the different kinds of PrEP and who to use them in. We'll explain the importance of choice, describe new PrEP modalities that are in development. We'll spend a very short time on PEP, and then we'll move on to Doxy-PEP. And so this is the general outline of the talk. As I said, I'll devote a fair amount of time to PrEP, a little bit on PEP, and then Doxy-PEP. So let's start with the current PrEP choices in different populations. So what you can see is that there are 4 different types of PrEP that are currently available. There's daily FTDF, 211 FTDF, which I'll describe in a moment, daily FTAF, and CAB-LA, long-acting cabotegravir. And what you can see is that for people who are the insertive partner or for receptive anal sex, all 4 of those methods are currently recommended. CAB-LA has also been shown to be effective for receptive vaginal sex, and you can see that daily FTDF has been shown to be effective in all 4 types of exposures, including injection drug use. But just remember that people who are exposed through injection drug use are often also exposed sexually. So this is a really nice infographic that colleague Julia Marcus created that we sometimes use with patients to describe the difference between 2 daily PrEP regimens, TDF-FTC and TAF-FTC. You can see that the pill size is different. Heterosexuals and people who inject drugs have not been, TAF-FTC has not yet been tested in them, but we hope to get some information on women and TAF-FTC later this year. There are some differences in toxicities, namely kidney and bone issues with TDF-FTC, generally fairly mild, and then safety issues with TAF-FTC include small increases in LDL and weight, and more like people on TAF-FTC PrEP are more likely to go on statins and more likely to develop hypertension, according to a more recent study. And of course, the cost is substantially different between the two, with TAF-FTC being almost $2,400 a month compared to generic TDF-FTC. So this was discussed a little bit earlier, but the question is how much adherence is needed for daily PrEP. Model data suggests that you get 99% effectiveness with 4 doses a week or greater for men who have sex with men and for cisgender men. And there were some more recent data that suggested that even 2 pills a week have about 99% effectiveness, and that's probably because people were using it as 2-on-1 PrEP. But there were data on cisgender women recently that challenged this notion that you have to get women to take 6 to 7 doses a week or else it's not going to be effective. There was data from 11 demonstration projects in cisgender women globally that found that those who took it consistently daily, there were no infections. There was a 90% reduction, only 1 infection in the group who took 4 to 6 tablets a week. So it may be that you can still get very high effectiveness, even though the PK didn't suggest that based on PK levels in genital secretions, but it may be the blood that's more important, and we'll talk about that in just a moment as well. And then 61% reduction, even with just 2 to 3 tablets a week. So we don't need to withhold PrEP from cisgender women who may not be able to be adherent to a daily pill. What about gender-affirming hormones? Well, a number of trans individuals are concerned about PrEP interfering with their hormones. They do not interfere with the hormones. The question is the converse, which is, what about the hormones interfering with FTDF or FTAF? And we'll start with FTDF. There are some studies, but not all, that have shown that with feminizing hormones, you might get slightly lower tenofovir levels. Masculinizing hormones do not seem to have any effect on tenofovir levels with FTDF. And the converse is true with FTAF, where feminizing hormones don't seem to have any effect, but masculinizing hormones, while they didn't have an effect on blood or rectal levels, did decrease by 60% levels in cervical tissue. Remember that TAF-FTC is not currently recommended for cervical exposure, for vaginal exposures. As I said, we should be getting data later this year, but the meaning of this isn't really quite clear because it may be that it's really the blood levels that are most important in terms of protection, and you can also boost the levels of tenofovir in the blood by giving TAF-FTC or TDF-FTC with a meal. Now, IPERGAY tested this 2-1-1 PrEP, which is 2 pills 2 to 24 hours before sex, 1 pill 24 hours after that, and another pill 24 hours after that. But it might also be called 2-1-1-1-1 sex for PrEP for people who are having multiple episodes of sex. And you just keep taking 1 pill until 48 hours after the last sexual exposure, and you don't need to do the loading dose of 2 pills if the last pill was within 7 days. And how well does it work? Well, from IPERGAY, there was 86% efficacy in the randomized control trial and 97% relative reduction in the open label extension, so quite highly effective. We also know that CAB-LA is quite highly effective and was found to be superior to FTDF in 2 studies, one HPTN-083 in men who have sex with men and transgender women, and another one in cisgender women, HPTN-084, probably because people don't necessarily take their daily pills. And so there was a significant reduction in CAB-LA compared to FTDF, but really the best method of PrEP is the one that individuals will take. So how do you give CAB-LA and what do you do about missed injections? Well, you give injections at 0 and 4 weeks, and then it's every 8-week injections. The goal is to get it within 7 days of the target date. But also we're recommending that, and these are IAS-USA recommendations, that you provide FTDF to individuals on CAB-LA to cover gaps. And if the gap is less than 8 weeks late after the loading is complete, then you just tell them to start taking their FTDF if they miss their injection visit and then administer CAB-LA as soon as possible. The IAS guidelines say if it's more than 8 weeks late. The FDA label says if it's more than 4 weeks late, then you reload with 2 doses at a 4-week interval. Now, one of the things that we have to be concerned about with CAB-LA is something called long-acting early viral inhibition, or the Levi syndrome. If you look at what happens in acute HIV, we know that there's an explosive amount of viral replication. People are often quite highly symptomatic. They turn positive on antigen antibody tests and on RNA tests. It's really rare for there to be assay reversion, so once people are positive, they stay positive. It lasts for 1 to 2 weeks. Transmission is very likely because of very high levels of viral replication, and usually there's no drug resistance unless it's transmitted drug resistance. Whereas people who are on long-acting injectables, and so far we have this data for CAB-LA, but we expect it for the other long-acting agents, there's a smoldering infection with minimal, variable, or often no symptoms reported. You might need an ultrasensitive RNA test to detect it. You can get assay reversion, flipping back and forth between positive and negative, and that can go on for months. And so even though transmission is very unlikely to occur, resistance can occur quite rapidly in these settings. So these are some data from HPTN-083. This is the total number of infections, 34 in people who got CAB-LA, and that's over with over 4,600 person years of follow-up. So it's quite rare that this happened. INSTI resistance occurred in part in people who were positive at the time of infection, at the time of initiation, or who were infected during the CAB lead-in phase. But there were also 6 people who were infected with on-time injections, and all 6 of them developed INSTI resistance. And so what's suggested is that RNA screening be done before starting or when you need to reload with CAB-LA injections. But what about follow-up testing? Do you need to do RNA each time? And there were some data that were presented at CROI this year where rapid tests combined with antigen antibody tests have excellent performance for oral TDF-FTC or FTDF in PrEP. And so we really don't think you need to be doing RNA testing for oral PrEP. But, and there was another study that suggested that if you need to get antigen antibody tests in order to rule out, you don't want to just do an antibody-only rapid test. But, and this is, remember this one because it's part of your test. If there are 2 positive tests, they had high positive predictive value, or 2 negative tests. So that's a rapid test plus an antigen antibody test, or 2 rapid tests. If they agree, if they're both positive or both negative, it had very high positive and negative predictive value. And so the conclusion from this was in settings where sensitive viral load testing is not available or feasible, rapid tests and antigen antibody tests when giving the same result are sufficient in the setting of follow-up of CAB-LA PrEP. So we may not need we may not need RNA testing in follow-up for CAB-LA. And there was another study that also found that antigen antibody testing was sufficient. But there will be more data coming out hopefully this summer from HPTN-083 where they are doing RNA testing to see how much do you actually pick up if you do RNA testing in follow-up. So let's talk next about the impact of choice. There was a great study reported at CROI this year on the SEARCH trial, which randomized people to either receive something called dynamic choice or standard of care. And the standard of care was referral to their local Ministry of Health clinics. Now, dynamic choice was they could both choose the kind of PrEP or PEP that they wanted, but there were other kinds of supports that were given. They had a choice of service location, HIV self-testing, 24/7 access to a clinician, and some other kinds of supportive strategies. The extension study of the dynamic choice study did include CAB-LA as one of the choices. And the eligibility was you had to be at least 15 years of age, have a negative rapid test, and report a risk of acquiring HIV. The extension study included almost 1,000 people equally divided between the dynamic choice and standard of care arms. About 50-50 came from Kenya and Uganda, 73% were women, and 30% were under the age of 25. This is the really dramatic result that was seen. The blue bars are the people who got dynamic choice and how much prevention coverage they achieved compared to the almost 70% compared to the 13% in the standard of care arm. So really choice made a huge difference as well as the other supportive strategies. But you can see the dynamic choice on the left column versus the standard of care on the right column. Over half of the participants, including both men and women, started CAB-LA. A large number, and of those, 42% were not on any prevention product in the prior month. So we were capturing more people with CAB-LA, which is really what you want to do to have an impact on the, at a population level. But a lot of people also took oral PrEP, and 28% took 2 or more products. So giving people choice and allowing them to switch if whatever they choose is not suiting them is really important. And it had an actual important and statistically significant effect on HIV incident infections, with no incident infections in the dynamic choice arm compared to 7 in the standard of care arm. And in addition, there was an infant born to a woman who became infected in the standard of care arm, who also became infected, that didn't count towards that number of 7 infections. So let's talk a little bit about PrEP challenges and strategies. These are the overall trends in PrEP prescriptions among people who could benefit from PrEP from 2019 to 2022. And you can see that it's a little over a third of people who might benefit from PrEP who are on PrEP in 2022, or who at least received a prescription for PrEP. But we've got these huge disparities. And so this is white individuals, Latinos and African Americans, and you can see that we've got these huge racial and ethnic gaps, as well as this is people assigned male at birth versus people assigned female at birth, big gender disparities. So we're not getting PrEP to the very people, in particular, when you look at racial, ethnic disparities and the number of new infections, we're not reaching the populations who need PrEP most. Another population that needs PrEP is people who inject drugs, and these are data from the National HIV Behavioral Surveillance Study done in 2018 and again in 2022. For those of you who are local, you can see that Chicago was one of the sites of the 19 US cities. And this was in people who inject drugs who are HIV negative. And what you can see is PrEP awareness went from a little over a quarter to a little over a third. So it was a statistically significant increase, but that still meant that close to 2/3 of people who inject drugs in 2022, which was a decade after PrEP was licensed in the United States, were still not even aware that PrEP existed, and only 1.2% in both years actually had taken PrEP. So we need to find ways of getting PrEP out to people who inject drugs as well. And so how do we actually start to think about how we gather PrEP use, how we improve PrEP use in people who are not using it? Well, one of the ways that we don't do it is to emphasize that it's for people who are at extremely high risk, because most people don't identify as high risk. It can pathologize normal, healthy sexuality, and CDC now recommends that PrEP be discussed with everyone who's sexually active, including people who inject or use drugs. And so we don't want to really focus this on high risk, but rather focus on what people might, the ways in which people might benefit. And these are the things that people report when they use PrEP, that it reduces their worry about HIV, that it can increase intimacy with partners and enhance feelings of agency over sexual health. So we really need to be framing PrEP as a positive sexual benefit, not that this is for you because you're at high risk. And then I just wanted to briefly review, we've got a really robust pipeline of future PrEP agents. I'm going to tell you about 5 long-acting PrEP agents and 2 event-driven PrEP agents. The first is lenacapavir, as you know, an every 6-month subcutaneous injection. It's currently being tested in women in sub-Saharan Africa and in gay and bisexual men who have sex with, and other men who have sex with men, and transgender persons globally. And there are studies that are going to follow up in people who inject drugs and US women. So we should have some data potentially even later this year on the women's study, and that's where we'll also get the data on FTAF. Ultra-long-acting cabotegravir was reported at CROI. The PK suggests that it could be given IM and possibly sub-Q every 4 months, not every 6 months, but every 4 months. So that would be a big improvement as well. There's MK-8527, which is the sister to islatravir. It's a reverse transcriptase transcription translocation inhibitor, and it's currently in phase 2 testing as a monthly oral pill. So that could, again, serve a need for a particular subpopulation. There were data presented, and this was just mice studies so far, so it's still in very early development, but ultra-long-acting dolutegravir that might be able to be administered as what's called an in situ forming implant subcutaneously, which is actually removable, that could be given as infrequently as once a year. And then there are broadly neutralizing monoclonal antibodies that are being tested in combination and given every 6 months as an IV infusion. And then in terms of event-driven PrEP, tenofovir is being studied as a rectal douche, which would be behaviorally concordant because some people who engage in anal sex also douche. And then FTAF, instead of 2-1-1 PrEP with FTDF, this would be 1-1, 1 pill before, 1 pill after, and that's currently in evaluation. So let's talk briefly about HIV PEP. This is the curve in blue that shows PrEP prescriptions in the US over the last 10 years, and then this is the curve for PEP. which means we're not making any headway in actually dispensing PEP to people. It's about 14 to 18,000 prescriptions per year. It's something that we're really underutilizing, that we should be able to be counseling patients about, particularly if they're not on PrEP, that this is an option for them. There were data presented at CROI on BIC FTC TAF showing, very high rates. 90% took the pill daily for at least 28 days. We know that only 10% experienced adverse events of grade 2 or greater, and so this is a very well-tolerated daily pill. Unfortunately, there was also data presented that, could cabrylpivirine be used as PEP, and that was tested in a non-human primate model after a rectal SHIV exposure. Unfortunately, 2 of the 6 animals who were given cabrylpivirine after their exposure were actually infected. And so it looks like the PK perhaps of cabrylpivirine is not such that it can be used as PEP. And then we'll turn now to Doxy-PEP. So the first were some disappointing data. Doxy-PEP in Kenyan young women were not effective, and Doxy-PEP is 200 milligrams of doxycycline taken within 24 hours after sex, but up to 72 hours after sex. It didn't provide protection, and so the question was this because of the biology, because the PK suggests it should work, or was it because of adherence? And so some data were presented at CROI that 50 women who had been assigned to the Doxy-PEP arm had hair samples tested for doxycycline, and only 29% were positive. And so that suggests that it was poor adherence that likely contributed to the negative outcome of the study. We don't have data now on whether Doxy-PEP actually works for women. So we do need more data, and there are studies that are currently in planning and should be launching soon. There were data presented on Doxy-PEP from 2 randomized controlled trials. From the Doxy-PEP study, this was a study in men who have sex with men and transgender women who had had an STI in the past year, who were living with HIV or were living without HIV but on PrEP. And they were randomized to get Doxy-PEP or no PEP. They showed an 80% reduction in chlamydia and syphilis and about a 50% reduction in gonorrhea in the original study. So what was presented at CROI this year was the open label extension, in which after the DSMB stopped the randomized control trial because of its high level of efficacy, the standard of care arm were offered Doxy-PEP. And both the standard of care arm and people who were in the Doxy-PEP arm could continue for up to 12 months. 82 of the 83 participants who were randomized, had been offered Doxy-PEP in the standard of care arm chose to take it. You can see here that there was some racial and ethnic diversity, but it was predominantly men who have sex with men in this study. And despite an almost doubling of number of sex partners and condomless sex reported by the standard of care arm after they started taking Doxy-PEP, there was about a halving in the number of STIs. So it was highly effective, and it didn't matter that some sexual risk increased. There was still a substantial reduction in the number of STIs and a sustained reduction in STIs in the people who had initially gotten Doxy-PEP. So there were data from the Doxy-VAC study. You heard a little bit about this earlier in hearing about the 4C meningococcal B vaccine component. This was a factorial design where people were first randomized to Doxy-PEP or no PEP, and this was men who have sex with men on PrEP who had a bacterial STI in the prior 12 months. And then they were also randomized to either get this meningococcal B vaccine or no vaccine. And this was a somewhat less diverse population. It was 88% white, 88% were employed. The median time to Doxy-PEP was about 15 hours. Over 70% reported using Doxy at their last sex act, and that was confirmed by measuring it in both plasma and in urine. And you can see that, again, it was about an 80% reduction in chlamydia and syphilis. This case, a 33% reduction in gonorrhea. There's higher levels of tetracycline resistance to gonorrhea resistance to tetracycline in France, where the study took place. In fact, 100% of the baseline samples of gonorrhea were tetracycline resistant, but 12.5% in the no Doxy-PEP arm and 35.5% in the Doxy-PEP arm did acquire high levels of resistance to Doxy-PEP or to tetracycline. And you heard that the 4C meningococcal B vaccine there was a modest reduction. It was not statistically significant, and we are awaiting the results of the phase 3 trial that's currently underway. So the big question is, who should be offered Doxy-PEP? And the study eligibility were people, men who have sex with men and transgender women who'd had a bacterial STI in the past year. And the question is, do you restrict it more, which would maximize the benefit to risk ratio? It would minimize excess antibiotic use, but it would be more complex to identify candidates, and it would reduce your reach and impact. Or do you go with broader use, where you meet patient demand, it might be more anti-stigma, and there would be a greater reduction in the absolute number of STIs, but you would be using more antibiotics? And so the current guidelines don't agree, not surprisingly. The US CDC draft guidelines that were issued last fall suggested that they were going to follow the study guidelines, which were people who had had an STI in the past year. I'm going to describe to you what's been going on in San Francisco, where we have somewhat more liberal guidance, where it's recommended for the study population, but it's offered to a broader group, including trans women, trans men, and men who have sex with men with multiple partners, but without an STI diagnosis in the past 12 months. So these were data that were reported at CROI as well. And on the left was from a CBO-run sexual health clinic. On the right, a municipal sexual health clinic. And what you can see is that there was a significant reduction in chlamydia and in syphilis when they compared people who were seen in the clinic who were on Doxy-PEP versus those who weren't on Doxy-PEP. And what was really remarkable was this, in this one study, they showed that the rates of STIs were quite a bit higher in the people who were taking Doxy-PEP before they started Doxy-PEP, and then afterwards it actually decreased so that they looked more like the non-Doxy-PEP arm. But substantial reductions in chlamydia and syphilis, no significant reduction in gonorrhea. So remember that as well for your test. And then what we did is we looked at citywide, were we having an impact on chlamydia and early syphilis in men who have sex with men and transgender women, regardless of whether people were on Doxy-PEP. And what was done was what we call an interrupted time series, in which we looked at the rates of chlamydia shown on the left here, and projected out, modeled out, what should the rates have looked like had they continued along the same lines, and what was actually seen. And there was a 50% reduction in the rates of chlamydia compared with what would have been expected had the trends before the guidelines went into place had continued. And similarly, a 51% decline in syphilis. So there was early evidence of potential population-level effects of Doxy-PEP on chlamydia and syphilis, but not gonorrhea. What we do need is longer follow-up and to replicate findings in other jurisdictions, and we do need more information on antimicrobial resistance and systems for AMR surveillance. Providers should support their patients in assessing their need for, interest in, and use of Doxy-PEP. And guidelines for Doxy-PEP can and should evolve as evidence emerges informed by community input and clarity around the goals of Doxy-PEP, because we don't yet have targets for Doxy-PEP in the way that we do for PrEP. So that's my presentation, and happy to take questions.
Thank you again for that wonderful tour de force around PrEP and PEP. I'm sure you all remember every word of it. So as you can see, there's been a lot of data accumulation about PEP and PrEP over these last years, and it's really a rich set of data that Dr. Buchbinder has reminded us of. So we have a lot of questions for you.
Okay.
So the first has to do with what have the studies shown with regard to Doxy-PEP in adolescents younger than age 18? Any work in that area?
We don't yet have data on that. So the clinics in San Francisco that looked at Doxy-PEP and its impact only had people 18 years of age and older. We're actually getting ready to launch a study in the Adolescent Trials Network in which we'll go down to the age of 13 to see and offer Doxy-PEP to people and see what the uptake is like and rates of STIs in that population. But we don't yet have data on that population.
Okay. Excuse me. Okay. A handwritten question. Some studies suggest PrEP increases the frequency of STIs. Is this from increased risky behavior or increased testing?
Yeah, that's a great question. We don't really know. So we do sometimes, in some studies, we see an increase in STIs in people who are on PrEP. Remember that the people who are on PrEP are the ones who actually are the ones who might benefit from PrEP. And oftentimes, they're the ones who have higher rates of STIs. And there was at least one study that suggested that the increase in STIs started before people started PrEP. But we also know that we test much more regularly when people are on PrEP. We're generally testing every 3 months for STIs. And so it may be just a consequence of that. That's why both of the Doxy-PEP and the Doxy-VAC study did include men who have sex with men and transgender women who are on PrEP because they're the ones who might benefit most from Doxy-PEP.
Okay. Some of these are fairly complex questions, so I'm just trying to understand what's actually being requested. So if Doxy-PEP is 200 milligrams 24 to 72 hours after unprotected sex, if a patient has sex on day 1, takes Doxy within 24 hours, but has sex again the next day, is that first dose sufficient to cover that encounter, or do they need to repeat the dose?
That's a great question. So the way that things were done in the US was that people were taking it on a daily basis as they needed it after sex. But in France, the way they did it was no more than 3 times a week. So they would say you are covered and you don't need to retake the Doxy-PEP. So it worked equally well in both places, so you probably don't need to take Doxy again. But in the US, what our guidance has been just take it no more than 1 pill a day, but every day that you have sex.
Okay, I think this is kind of a related question or comment. What about Doxy-PrEP? In other words, taking Doxy 3 times a week?
Yeah.
I think you just covered that point.
Yeah, and in fact, in the Doxy-VAC study and in the Doxy-PrEP study, generally people only took it about 3 to 4 times a month. So Doxy-PrEP would probably only be needed for people who are quite highly sexually active, and then probably 3 times a week may be sufficient.
Okay, then next question relates to long-acting CAB. How do you counsel people about time to protection after the first dose of long-acting cabotegravir?
Great question. So we don't really know what the time is to protection. What we think from the PK is that it could take up to 7 days. And so some people are covering the first week of after CAB-LA with oral PrEP, with FTDF or FTAF. Just to be able to provide protection during that first week, because we don't think that the CAB will kick in necessarily, it won't kick in immediately, as demonstrated by using it for PEP.
That kind of mirrors what you talked about with the animal data.
Yes.
Okay. As mentioned in an earlier talk, is there guidance around interpreting RPR titers for patients on Doxy-PEP? Has anyone started thinking through this yet?
People are thinking through it. There are no good answers at this point because it's really hard to study. How do you figure out if somebody should have decreased their titer and didn't decrease their titer. So the people in the Doxy-PEP and Doxy-VAC study arms will have gotten syphilis testing, RPR testing, over time, and so they will be able to see what happened to titers, but we don't yet have answers to that question, and it's a rather thorny one to study.
Okay, another syphilis question. Do you have any thoughts on the rise of syphilis being related to our destigmatization and excellent treatment of syphilis, therefore less fear of acquiring syphilis?
Well, what people say who are on Doxy-PEP is that they really appreciate the decrease in stigma around preventing getting syphilis. So I do think there's been some destigmatization, but it also, there's still some stigma associated with syphilis, and so Doxy-PEP does help with that. It's hard to say. I mean, we're seeing rising rates of syphilis as well in cisgender women, and rising rates of congenital syphilis. And so we really do need methods of protection for women as well, and I don't think it's necessarily a reduction in stigmatization around syphilis. I think it's just sexual practices and transmission networks and so forth.
And you touched on this next question a bit, but it's one of the thornier concerns about Doxy-PEP. And can you comment on the risk of increasing rates of antibiotic resistance and in particular the impact on the microbiome of increasing use of Doxy-PEP?
Yeah, those are things that are currently being sorted out. So what we know is that from both the Doxy-VAC and the Doxy-PrEP study, that there was an increase, a slight increase. It wasn't a huge increase, but there was some increase in the rates of tetracycline resistance or doxycycline resistance in the people who acquired gonorrhea. We don't use doxycycline to treat gonorrhea because of background rates of resistance, and the horse is sort of out of the barn in that regard. The question is, are we also getting off-target resistance? And in terms of the microbiome, there were some data presented at CROI that there was an increase in tetracycline gene expression in the Doxy-PEP arm compared to the non-Doxy-PEP arm, but there was no change in the diversity of the microbiome in the people who were on Doxy-PEP. So we're still trying to tease out what it means. There's a larger study that should be launching pretty soon in 5 cities in the US that are rolling out Doxy-PEP to study antimicrobial resistance and to dig deeper into that question.
And just as a byproduct of that question about off-target resistance, has anyone evaluated sort of some of the other infectious diseases that are normally treated with doxycycline? Has there been any evidence of increasing resistance in that setting? So
the one bacteria that was tested in the Doxy-PEP study was Staph aureus, and there was no change in MRSA, but there was an 8% increase in doxy resistance. It went from 5% to 13% in the Doxy-PEP arm compared to the non-Doxy-PEP arm.
Okay. The microphone?
Yeah, interested in the 2 HIV tests rather than a viral load. Are you doing that currently? And we did that when we first started using rapids, and it was interesting. But is that 2 tests on 1 sample? Is that 2 different samples a little bit apart? And have you ever gotten anybody to pay for 2 HIV tests in 1 day?
Yeah, great question. So the 2 tests we do get 2 tests paid for in that we do a rapid test and an antigen antibody test. And so that we can do. And because we're sending the antigen antibody test off to the lab, we're waiting for those results to come back. The 2 rapid tests were studies that were done outside of the country in HPTN 083. And in that case, they were doing 2 tests off of the same specimen and just being sure that they were concordant so that they were being read appropriately. I think we'll have a lot more data on this question of RNA for viral, RNA testing for for follow-up visits with CAB-LA this summer. We're hoping to see more data out of the HPTN 083 and 084 studies. So more to follow on that, but I think we're going to be moving away from, at least the recommendations may move away from requiring RNA testing because it's so difficult for some people to get and so much more expensive.
I think 2 more questions on Doxy-PEP. Would you consider Doxy-PEP in high-risk cis women?
We do consider Doxy-PEP in high-risk cis women with counseling about the fact that we don't have data yet that it works in that population, but particularly with the high rates of syphilis right now in women, they may benefit from it, and so we do counsel women who might be at high risk for STIs, but it is a shared decision-making kind of process.
And the last question I have for the moment, were genital versus extragenital positivity testing studied in Doxy-PEP studies?
They were. So they were, it was 3-site testing. It was urine, rectal, and pharyngeal samples. And there was a decrease in STIs in all 3 sites for both gonorrhea and chlamydia.
Great. That's kind of a wrap for the questions I have on Slido and cards. If there are any other questions from the audience? If not, I think we can close this session, and Dr. Volberding will be introducing our next speaker. Thank you very much.